Hi everybody, this is the first of my video recording lectures that I want to try and provide you every week to really highlight a lot of the content that we've been discussing, a lot of the material that we're going to go over, and I really wanted to take this opportunity to really highlight some of the stuff that's posted on Blackboard. So you saw my little introduction, you have the two Blackboard discussions, and then what I want to do is review the key terms, the substance abuse criteria, the integrated summary, and the stages of change. Those are things that are going to be really integral in the case studies and the readings that you're going to be experiencing moving forward. So I'm just going to go right onto it. So if you have the key terms available, I would definitely pop that open because I'm going to be reviewing it. Okay, so key terms, excuse me, things to always keep in mind, right? These are the things that you always want to really think about and that I may reference moving forward. So the first thing is, in the key terms, is releases of information. So we referenced this, sorry, my phone is like acting really obnoxious right now. I'm sorry. The first thing that we reference is this law called 42 CFR Part 2. Okay, so many of us are familiar with HIPAA. HIPAA is the medical law that protects medical information. Substance abuse information is protected by HIPAA to a certain extent, but the real law that we follow is 42 CFR Part 2. Okay, and when you're in the field and when you're making decisions, what you should be doing is thinking, is this 42 CFR compliant? What would 42 CFR say? Or how am I bound to 42 CFR? Okay, this is something that should be in your lingo moving forward. This is one of the most crucial things that you need to know in entering this field. Okay, to release any information to anybody regarding a client that you're working with, whether it be in case management or in a much thicker clinical setting, you have to comply with 42 CFR. You cannot release any information without that client's permission. And even if you have their permission, it needs to be very specific on a release, and that release must specify 42 CFR in it. And in week 3, I think we're going to get much more deep into that. Okay, but I just want you to be aware of it. There are only 4 reasons why you could release information without a client giving consent. And it's if they're a threat or a danger to themselves or someone else, if a child, elderly, or disabled person is being abused, neglected, or exploited, if they commit a crime in the premises in which you're working with them, or if there's an actual court order signed off by a judge. Now, to be clear, a subpoena is not a court order. A subpoena is something that is provided by an attorney to have you go to court. A court order is signed off by a judge. We see these very often in times of a DCF involvement or in like a parent-child custody battle happening in probate court. One parent is saying this about the other parent. This parent is saying this about this person. So a judge may say, okay, I'm going to appoint a court investigator and they're going to look into this. That court investigator can get whatever information they're looking for, regardless of what it is or where it is, because it is ordered by the judge for the sake of investigating this particular issue. Okay, so really consider 42 CFR. We're going to be talking about some ethical cases that are really going to highlight this. Okay, the next one is standard of care. So this is real important. Standard of care is what a reasonable and prudent practitioner with the same or similar training should have done under the same or similar circumstances. Okay, this is really important because when you're doing what we call consultation, which is part of the 8 domains or the 12 core functions, it's basically what you need in order to be licensed. Okay, you have to be able to consult. Not everyone is going to make the same decision, but everyone with the same training regarding particular field should make this a similar decision. So for example, let's say I get a client who comes to me and says they want to kill themselves. Whatever I do moving forward for that client, or however way I choose to intervene with that client, other practitioners, other clinicians with the same or similar training should act in a similar way. if someone came to me and said, I want to kill myself, and I say, well, I call your bluff, I don't think you're really going to do it, and then they go and they blow their head off, we got a problem, right? Now, if all of a sudden their family decides to bring me to court and I say, hey, I was just doing what I thought was best, and I thought that they were lying, and I thought that they were pulling a bluff or whatever, a expert witness can come in to determine if what I did was on par with my training and my license. So that expert witness could come in and say, no reasonable trainer, supervisor, or clinician would encourage someone to take their life or to act in a certain way, or would call their bluff when they're saying that they want to commit suicide. They would never do that. Therefore, this practitioner, this clinician, acted in an unethical, unreasonable way. They did not act within the standard of care of others. So now that is let me just be clear, I would never say that to a client. That is a very, very generic example, very crazy example that I just used to clearly create a point. Now, in the event you ever have a client or anyone tell you that they want to hurt themselves, then you should most definitely intervene. You can call 911, say, hey, I need some help. This person wants to kill themselves. Call crisis, call your supervisor, call someone, and definitely talk to that person. So now that that's out of the way. So you really want to be able to create that, that standard of care, right? So it's not just in crisis situations, it's also in, recommendations for treatment. If someone comes to you and says that they're detoxing off of alcohol, a good standard of care would be, medical intervention, detox, consulting with a physician, making some kind of referral. If I send them home, to just sweat it out and something bad happens to them, that's not an appropriate standard of care, okay? So what's going to happen is in the discussion boards that you're going to be engaging in moving forward, what we're all going to be doing is learning how to practice our standard of care, learning how to practice creating decisions and referrals, or making decisions based on what we feel is best for the client, but is also reasonable in what other people would also do as well. Okay. The other thing that we're going to discuss briefly is the Tarasoff rule. Okay. So the Tarasoff rule is when a therapist determines, pursuant to the standards of their profession, so pursuant to their standard of care, should determine that a patient presents a serious danger of violence to another person, he incurs the obligation to use reasonable care to protect the intended victim against such danger. And we're again in week 3, we're going to review this much more thoroughly. But basically what this rule says is that if a client comes to you saying that they want to hurt someone else, or someone else may be in harm, it is your responsibility as a practitioner to try and alert that person that there is intended harm on them. And we're going to get into that, okay? The next thing is clinical judgment. It's the conclusion or enlightened opinion, so your opinion, your conclusion as a practitioner, as a clinician, that you gather up based on the process of observing the client and reflecting and analyzing the observable or available information or data. So basically what's happening is you're sitting with the client, they're telling you all of this information, and you create a clinical judgment on what is best for this person. So when I make a recommendation, so for example, if I say, I recommend IOP, and that client says why, I should be able to say, you have had a history of, chronic drug and alcohol use. You've had unsuccessful efforts to stay sober. The times where you have been sober have been primarily on self-will alone. You know a lot about how to be, a person with an addiction, but what you lack is the ability to really understand what it means to have an addiction, what it means to be sober, what it means to be in recovery. You lack sober supports, you lack structure in your day, and IOP is able to give you all of this stuff, et cetera, et cetera. So your clinical judgment is basically you gathering up all this information about a client and creating a good judgment, a good clinical opinion about them or about their care. Okay. The next one is the 8 domains or the 12 core functions. Basically what happened is before I even got my license, there were the 12 core functions, right? And it's all the different areas that you need to have clinical supervision in order to get licensed. Well, they ended up shrinking them down to now they call it 8 domains. So they take a couple of them and they kind of push them all together, like clinical evaluation, screening, intake, orientation, assessment, whatever. So they kind of pull all those together. As you're going through your licensing process and as you're going through your training, and when you go to sit for your test for the license, all of these things are going to appear. So it's important to be familiar about what the 8 domains and what the 12 core functions are, and they're noted here. Okay. The other thing too is to note the definition of a crisis, which is a critical phase in a person's life when his or her normal ways of dealing with the world are suddenly interrupted. Now, this is really important because a crisis to you or me may be completely different from a crisis to someone else. So it's important for you to treat every individual's crisis as a crisis as it is to them. And through your training, what you'll end up realizing is many people will have a crisis, but it's really just a problem. So what we do is we talk to them and we try and help them identify the difference between something that's a problem, something that's a legitimate crisis, and how they can best intervene in that. But we're definitely going to be reviewing some cases where crisis may be involved. The other thing is trauma. So trauma is defined by the DSM-5 as any situation where one's life or bodily integrity is being threatened. These are also typically large T traumas, so we call them large T or big T and little t or small t. While small t traumas, for the most part, would not lead to the development of pure PTSD, it is possible that a person can develop some trauma responses. In other words, the person may experience increased distress and decreased quality of life. So for some people, they may experience really big traumas. So for example, I'm driving down the highway in a rainstorm and I hydroplane and I get into a car crash. Now I'm going to be really hesitant and possibly have some anxieties about driving in a rainstorm. Whereas a little t would be I was driving and I was on the highway and all of a sudden I saw a car crash in front of me, or I drove by a car crash that happened because of inclement weather. So that might not completely threaten my bodily harm, but it's enough to cause enough anxiety where it may impact me in a certain way. Okay. The next one is the ASAM criteria. So ASAM stands for the American Society of Addiction Medicine, and think of them kind of as like the American Pediatric Society or American Psychiatric Society or Association or whatever it may be, right? And basically they create best practices and they create best standards for giving care, and a lot of credited agencies, whether it be Providence Center, AdCare, Spectrum, High Point, whatever, typically use the ASAM criteria when providing treatment. So ASAM's treatment criteria provides separate placement criteria for adolescents and adults to create comprehensive and individualized treatment plans. So what ASAM does is they say, hey, look, if you have clients that meet this criteria, then they should meet in this level of care. If they meet this criteria, they should be in this level of care, and so forth and so forth. So adolescents and adult treatment plans are developed through multidimensional patient assessments, or 5 broad levels of treatment that are based on the degree of direct medical management provided, the structure, safety, and the security provided, and the intensity of treatment services provided. So we're going to get into that when we start doing the integrated summary. We're going to see the 6 dimensions, and we're going to review that, and that's all based off of the ASAM criteria. Okay, the last thing that's on here, and I really appreciate, is the recovery definition for mental health and substance use disorders. Now, this is my favorite recovery definition. I've seen a lot of them, but this is the best one that I can identify. And what it says is that it's a process of change through which an individual improves their health and wellness, lives a self-directed life, and strives to reach their full potential. I have this memorized, honestly. And the reason why I love it so much is that it does not mention a mental health disorder. It does not mention a substance use disorder. It mentions the person as a whole. And that's one of the things that we want to treat. We're treating the whole person, not just the addiction, not just, their active use or anything. We're treating the whole person. And we all know, for the most part, I would assume, I don't know any of you, but I would assume that when you are removing the drug or alcohol from a person's life, That's just one small piece of it. Now you got to deal with the hardest part, which is everything else. Okay.